Hello, you're welcome to this video. I'm going to take you through respiratory distress syndrome, also known as RDS. So respiratory distress syndrome is a condition which commonly affects babies that are born before term, in which there is insufficient production of surfactant in the baby's lungs, leading to difficulties in breathing. The causes of RDS includes immature development of the respiratory system or inadequate amount of surfactant in the lungs. RDS is the leading cause of respiratory failure in preterm neonates. It is more common in males than females. Okay, so the predisposing factors of RDS includes prematurity, which is due to immature lungs, asphyxia leading to epithelial tissue damage in the lungs, hypoxia due to increased pulmonary vascular resistance, metabolic acidosis due to prolonged hypoxemia, maternal diabetes due to hyperinsulin, anemia, which impairs also production of surfactants, meconium aspiration, which causes partial or total air obstruction, delivery by cesarean section for babies delivered at term, and it's due to being subjected to the chest contractions since they do not pass through the bony pelvis. Also of oligohydramnios, which leads to premature labor as there is less amniotic fluid. Thereby, the fetus is in direct contact with the uterus, which can trigger contractions. So these are some of the predisposing factors. Let's look at the pathophysiology. So when it comes to the pathophysiology, respiratory distress syndrome results from deficiency in pulmonary surfactant, which is due to lung immaturity. If birth occurs before 35 weeks, the premature infant may not be able to cope for a long time as a result of immature lungs. Immature lungs with deficient pulmonary surfactant develop pulmonary vascular resistance. The infant may breathe with minimal difficulties initially, but as the surfactant present progressively reduces, the respiration becomes labored. As a result, infant becomes fatigued and more alveoli cannot be opened. A surfactant-deficient lung is characterized by collapsed air spaces alternating with vascular congestion and hyaline membrane. Pulmonary vascular congestion may lead to pulmonary hypoperfusion. Hyaline membrane lines the air spaces, hence blocking gaseous exchange. As a result, blood passing through the lungs is unable to pick up oxygen and unload carbon dioxide. Blood oxygen levels falls and carbon dioxide rises, resulting in blood acid level and hypoxia, owing to progressive atelectasis and pulmonary hypoperfusion. Hypoxia and hypercapnia may result. Hypoxia consequently results into anaerobic glycolysis, causing the production of glucose from glycogen, thereby forming lactic acid, which in turn leads to metabolic acidosis and drop in blood pH. Increased acidosis in turn leads to capillary damage and necrosis of the alveoli, which again suppresses the production of the surfactant with increasing atelectasis. Therefore, respiratory distress syndrome occurs. I hope the pathophysiology is clear. Okay, let's look at the signs and symptoms. So one of the signs and symptoms is tachypnea. So you're going to notice that the breaths are going to be above 60 breaths per minute due to an attempt to increase minute ventilation to compensate for a reduced tidal volume and increased dead space. The other sign and symptom is subcostal retractions, as the infant is forced to generate increased intrathoracic pressure to expand the poorly compliant lungs. So that's when there's going to be that subcostal retractions. Then the third sign and symptom is grunting respirations. So these grunting respirations will result from the partial closure of the glottis during forced expiration. The other one is chest muscle indrawing or indrawing of the sternum and the chest muscle. So this is due to increased resistance of the collapsed pulmonary alveoli. Okay. There is also going to be central cyanosis. So as an infant becomes progressively distressed, cyanosis become evident due to poor oxygen perfusion to the tissues. The last sign and symptom that we can look at in this video is nasopharynx. So in an attempt to increase the respirations for more air entry, you're going to notice that there is a nasopharynx on this infant. Let's look at the medical management, specifically the investigations. So under the investigations, you are going to do physical examination. Under physical examination, you are going uh, do auscultation, which is going to review poor breath sounds with fine scattered crackles. Then inspection can also be done, which is going to show evident central cyanosis and also be able to show that the infant is not responsive to O2 therapy or oxygen therapy. Under the same inspection, you're going to notice nasopharynx, grunting respirations as well. Then a chest X-ray can be done, and it is going to show respiratory distress, and the lungs have a characteristic which is a ground glass appearance, which often develops 6 to 12 hours after birth. Then we can also do arterial blood gas, the ABG, to monitor the blood gases. So this one, it is going to show a diminished partial pressures of oxygen levels and increased partial pressures of carbon dioxide levels, and also reduced pH. We can also do full blood count. So a full blood count, we're doing it to rule out hematological conditions such as anemia and polycythemia. Blood cultures can also be done to rule out septicemia. So these are some of the investigations that you can do in an infant who has RDS. Okay, so let's continue with the management. Specifically on this one, we're going to look at the interventions. So the baby is nursed in an incubator or covered with blankets to maintain body temperature. If necessary, the baby may also be dressed in order to conserve some heat. We're also going to do some observations. So we're going to do frequent observations of temperature, heart rate, respirations, and color of the skin. So the temperature of the baby is taken rectally at regular intervals of not less than 4 hours to detect hypothermia. Normal temperature should be maintained in the range between 36.5 degrees Celsius to 37.5 degrees Celsius. The temperature of the incubator should be between 34 and 37 degrees Celsius depending on the baby's condition. We can also do cardiac monitor to record heart rate and variability. Then the urine samples are taken to the lab for glucose osmolality to exclude renal failure. The baby is observed for edema, oxygen flow, intravenous infusion, as well as passage of stool. Apart from that, we also do oxygen therapy. So the aim is to maintain the atrial tension in the normal range, that is 7 to 10 kilopascals in mature babies and 6 to 9 kilopascals in preterm babies. Administration of oxygen helps prevent brain damage by relieving uh, hypoxia. Another intervention that we can do is feeding. So a nasogastric tube or NG tube uh, can be used to feed the baby unexpressed milk. We can also look at the hygiene and also the skin care. So skin cleaning should be done gently. The salt nappies are changed to prevent uh, excoriation. Then a barrier cream is then applied to promote or to protect the skin. Then position of the baby is changed after cleaning. Then we can also look at prevention of infection. So frequent and effective hand washing should be done. Then maintenance of high standards of care at all times should also be done so that we are able to prevent infections. Restriction of visitors and personal handling of the infant should also be done, and we should also practice reverse barrier nursing. So all these are done to prevent infections. Okay, let's look at the prevention of RDS. So one of the ways that you can prevent RDS is prevention of preterm labors and births. If preterm labor is inevitable, mother may be given uh, betamethasone for at least 24 hours before delivery to increase production of surfactant in fetal lungs. Amniocentesis may be done to determine lesser things, fibromyalin. If no sufficient surfactant in liquor, delay cesarean section or induction of labor. Another way that you can prevent RDS is by controlling diabetes and hypertension to prevent preterm labor. Also make sure that there is proper monitoring of patograph to avoid prolonged labor. So these are some of the ways that you can prevent RDS. Okay, let's look at the complications of RDS. So one of the complications of RDS is bronchopulmonary dysplasia, which is usually due to the life-saving treatment used in RDS. We also have intraventricular hemorrhage. This intraventricular hemorrhage usually leads to brain damage. We also have pneumothorax, which is as a result of leakage of air from the lung cavities into the chest. Then we have patent ductus arteriosus, which may cause low oxygen and may prevent the ductus arteriosus from closing after birth as it should be. Then there's also metabolic acidosis, which is as a result of poor gaseous exchange in the lungs. Pneumonia is also a complication, which is due to aspiration of meconium and secretions. Sepsis is another complication. We also have pneumopericardium. We also have pulmonary interstitial emphysema as another complication. So apart from that, we also have atelectasis. So this is where there is a collapsed lung, which is due to inadequate surfactant to maintain the lung tension. So these are some of the complications that you can find in RDS. And now let's look at the nursing management. So when you're looking at the nursing management, first thing, of course, you need to come up with the aims. So some of the aims that you can have is to promote lung expansion, to promote adequate breathing, and also, of course, you can talk about maintaining circulations. Now, after those aims, you need to look at the environment. So in the first 24 to 48 hours, you should be able to nurse the baby in the intensive care baby unit, then nurse in a clean environment. Make sure that all the resuscitative equipments and drugs are available, and you should be able to do the procedures collectively. And then avoid unnecessary handling of the baby, and the environment should be noise free. After you look at the environment, you can do psychological care, of course, on the guardians. So you need to explain the condition to the caretaker, and all the procedures should be explained to the mother, explain that everything possible is being done to help the baby. Okay, so now after you look at the psychological care, you can look at the observations. Now, under observations, this is where specifically you're looking at the maintenance of breathing. So in this one, you need to clear the airway by suctioning, then position the baby on its tummy with the head turned on to one side. Then you should be able to raise the head of the baby on a pillow, then offer oxygen therapy. Okay. Then you should also do a Silverman's scoring of about every 15 minutes. Make sure that you check the vitals and the vital signs, that is the temperature, the pulse, and the respirations. So every hourly, you should be able to check that until the baby is stable. Then make sure that you weigh the baby after 2 days. Observe the fontanelle for any bulging or depression. Observe for a high pitched, uh, pitched crying. Then observe the eyes for jaundice, pallor, and also discharge. Then observe the mouth for sores or oral thrush. Observe the abdomen for any distension. Observe the cord for any bleeding or signs of infection. Check if the baby is opening bowels or passing urine. Then also make sure that you observe the reflexes like sucking reflex. Then observe also just the general condition of the baby. After you look at these observations, then you can look at nutrition. So under nutrition, if the baby is very sick, give intravenous fluids. As the condition improves, feed by cup or allow to breastfeed or feed via a nasogastric tube. Give the feeds per kg body weight. So that is on the nutrition. Then you also need to do skin care. So make sure that skin cleaning should be done gently. Soiled nappies are changed to prevent excoriation. A barrier cream is then applied to protect the skin. Then position of the baby is changed after cleaning frequently to avoid skin damage. After you look at the skin care, then you can look at rest and hygiene. So you need to allow the baby to have enough rest to promote recovery. Advise the parents not to be disturbing the infant while asleep. Ensure the environment is free from noise to allow the baby to rest. Okay. Now, when it comes to the hygiene part, you need to do top and tail. Okay. So on the hygiene part, we are also trying to prevent infection. So you can say hygiene and prevention of infections. So you can do top and tail. Then eye care can be done, coat care can be done. Also make sure that you clean the incubator with jig 1 to 6 twice weekly. Then change the soiled linen, limit visitors, encourage and washing, and also make sure that you should be doing damp dusting of the room. Okay, after you're done with the rest and hygiene, then you can do the IEC. Okay, you can do the IEC. So educate the mother or the parents on the condition, the importance of the reviewed dates, also the importance of under 5 checkups, the importance of exclusive breastfeeding, and also advise them to continue keeping the child warm. So this is the IEC that you can give to the parents as you are discharging the infant or the